from United Way, the Retire United group, and RSVP of United Way of Marathon County. Welcome. You are in the right location. As you joined this meeting, we did mute you and your microphones and cameras were turned off. Feel free to use the chat feature across the bottom if you would like to ask questions. And if you would like to speak to Dr. Thomas personally, you can certainly unmute yourself or raise your hand, and we will be monitoring those as the session goes on. If you go to the bottom of your screen, there are a number of icons across the bottom. One of them says turn off your camera. One of them says mute. If you go to the little bit to the right, it's there's an open share. You don't need that tonight. Then there are 3 little dots. You don't need that one. Then there is a hand raising across the bottom. If you'd like to raise your hand and ask a question, you certainly can, and we will be monitoring that. And then it's the chat feature. So it says show conversation, and that is where you can chat to everybody. And once somebody puts a chat in the message, there will be a little icon that shows up. So if you would like to speak to anyone, you certainly may do that. We will be monitoring that, so feel free to take a look at that. So hello, everybody. Thank you. My name is Sarah Olafson. I am the Director of Marketing and Communication at United Way of Marathon County, and you are in the correct location. We are going to record this event and share the presentation if appropriate after the event. If you are from the media, which we do not have any media people right here, please leave this meeting as it is not for media consumption. With that, I would like to introduce Dr. Jaren Thomas, who is board certified as an internal medicine physician with Marshfield Clinic. Dr. Thomas received his medical degree from the Medical College of Wisconsin at Milwaukee and specializes in adult medicine and is an advocate for preventative care and early intervention of chronic conditions such as diabetes, high blood pressure, and cardiovascular disease. He joined Marshfield Clinic in 2015. Dr. Thomas is married and they have 2 daughters. I have known Dr. Thomas for more than 25 years. Outside of medicine, I know that he is a Milwaukee Brewers fan. He enjoys running and played basketball. An interesting fact about Dr. Thomas is that he is a twin, and his twin brother is a pharmacist. So he is a doctor and his brother is a pharmacist. Not bad in the family. I would like to welcome my friend to this presentation, Dr. Jaren Thomas.
Thanks, Sarah. I didn't know if you'd claim me or not at all, so I appreciate that.
Absolutely.
I'm gonna try to start sharing my screen, but thanks for inviting me to kind of talk about diabetes here. Let's pull it up and put it into slideshow mode. Can you hear me okay and see my slides okay?
Yes, we can hear you and we can see your slides. Thank you.
Excellent. Well, when Sarah asked me to kind of do a talk about diabetes, I kind of tried to think about a way to approach it, because diabetes is a very large subject and I enjoy it, and I could probably talk for hours about it. And she told me about 15 minutes, give or take, plus or 5 minutes. And so what I decided to do is I decided to name my talk Diabetes in 2020, because there are a lot of things going on with diabetes and around us. And I put a question mark in quotations because I decided to phrase this as the question, using the questions I usually get from my patients. So a lot of my talk will be just directed on patient or questions my patients usually ask me about diabetes, whether how to prevent it or how they can treat it, maybe without medication or with, and we'll go through it that way. So my goals for the talk today include defining diabetes, discussing the risk factors and diagnoses or diagnosing diabetes, how to prevent it if we can, and discuss treatment for it. And then, because the coronavirus is kind of going on around us, some correlations with the coronavirus and diabetes. So to start out, we'll define diabetes, which is simply elevated blood sugars. I'm going to stop my dog, actually, because she's barking. Sorry about that. So elevated blood sugars or blood glucose. So when we order tests, it's for the blood glucose. And essentially the blood sugars are too high. And what happens really is we have a hormone called insulin that takes the blood sugars out of our blood, or helps our blood sugars go from our blood inside our cells, then helps make energy. And if we can't respond to insulin because we're either not making it or becoming very resistant to it, we have to come up with other ways to treat it or bring those blood sugars down. So a lot of times I'll have patients come in and say, well, why do I care? I feel fine. We find a blood sugar slightly elevated, but when we're feeling okay, why change anything? So high blood sugars affect a lot of areas of the body. We'll name a few of them, and we'll start with the eyes. we develop something called diabetic retinopathy, or the high blood sugars irritate the blood vessels behind the eyes and can lead to blindness if left untreated. So a big problem, in fact, it's one of the top 5 reasons of blindness in the world, is diabetic retinopathy. It also irritates our kidneys. It affects how our kidneys will filter things and the overall function. In fact, diabetes also is one of the top 2 reasons for going on dialysis or having what we call end-stage kidney disease. It also will affect our nerves. It often does so by irritating the smallest nerves in our body and the blood vessels to them. And they usually are in our fingers or in our toes. We actually call it stocking and glove neuropathy because a lot of the times it starts in our fingers and it starts to come up just like we would put on a glove or we would put on a stocking. And that can cause burning pain, numbness, tingling, and a lot of times people will come in the beginning and say, it feels like there's something just kind of bunched up under my sock, but it just can progress, so we have to control our blood sugars. It can irritate the heart and cause outcomes like non-fatal heart attacks or other heart diseases. We actually call it a coronary equivalent, meaning even if we don't know if we have heart disease, diabetes is considered pretty equivalent to it. Other illnesses that are very similar to it include heart failure, peripheral arterial disease, which if we get clogs in vessels that aren't in our heart, but like in our legs or arms, it's the same as an equivalent to the heart, just like diabetes is. A big problem also is infection and wound control. We irritate the blood vessels with high blood sugars, and we can't get good infection-fighting cells to those areas, so it's a lot harder to fight infections. And if we get the numbness from our nerves or other irritations, we can't get oxygen and we can't get other nutrients. So we sometimes have areas that actually just kind of die and it ends up with an amputation. It's actually the second or third cause of amputations behind trauma. So eyes, kidneys, nerves, heart, wound, infections, that's a lot of stuff that diabetes can affect. So people often come in and wonder if they'll get diabetes, mainly because they have a family history. If you have a first-degree relative with diabetes, your risk of getting type 2 diabetes at least is 2 to 3 times higher than normal. And if you have diabetes on your mom's side and your dad's side, you have a 5 to 6 times increase in chance in diabetes. And yeah, that probably is due to genetics and environment, being raised in a family with diabetes in it. But the genetics portion can't be denied for type 2 diabetes. We know ethnicity has been studied as well. Native Americans, African Americans, Hispanics tend to have a higher risk of it. A lot of that may be due to social economic class or factors, I should say, but that hasn't been studied, but their access to medical care might play a bigger role than the ethnicity itself. Obesity is a big factor as well. We use BMI a lot of times when we're talking about our weight, and then they take our height and our weight. Normal body mass index is 19 to 25. 25 to 30 is overweight, and 30 and above is obese. But a lot of the risk comes when our body mass index becomes 35 or over. Sleep is another big one. 6 or less hours of sleep a night increases our risk of diabetes. In fact, the sweet spot is about 8 to 9 hours. So when we're 8 to 9 hours, we have less of a risk. A lot of other evidence shows we do better with 7 to 9 hours for other aspects, but 8 to 9 is good to help prevent diabetes. Smoking is another one. With smoking, there's an increased risk of diabetes. So if you weren't sure if smoking was good or not, it's not good for you. So diabetes is another reason for it. Also, exercise. We often think of exercise going with diabetes, but there's lots of studies that show normal weight or slightly overweight people who don't exercise or are very inactive have an increased risk. So they've even done studies of prolonged television watching in people with normal weight, and the people who watch television longer have more of an issue. So a lot of times when we find a little bit elevated blood sugar, people say, well, what are the symptoms? Because again, I feel fine. The hard part about diabetes is often it is asymptomatic or silent. It takes a big event for someone to find out they have it, whether they have to get hospitalized and find out they have it from a heart attack or stroke and they find out they have the big risk factor of diabetes, or they end up having a other incident, whether it's something called DKA, which is just super high blood sugars that caused a lot of nausea and vomiting. So sometimes we just don't know, and that's a difficult thing. But the other symptoms we look for include frequent urination, increased thirst, and hunger. We call these the polys. Polyuria is increased urination, polydipsia is increased thirst, and polyphagia is increased hunger. Another thing that we actually see is weight loss, which is often surprising to people, but very uncontrolled blood sugars will often lead to weight loss. And blurry vision. Now, when we have diabetic retinopathy, the effect of the eyes long term, that's usually later in the diabetic process, but sometimes really high blood sugars can cause blurry vision as well. So how do we usually diagnose it, or how will we find out if someone has it? We tend to do yearly screenings, or every few years we check fasting blood sugars. And what happens is a normal blood sugar is usually 100 or less. Prediabetes, or elevated blood sugar, is usually 100 to 125, and 126 and above is when we find diabetes. So we often will use a fasting blood sugar yearly or a little bit less often. But then we've started using the hemoglobin A1C. And the hemoglobin A1C is the test we use to figure out if you have diabetes if your number is 6.5 or above. Now, people come in all the time and say, well, what's the hemoglobin A1C? I just want to know what my blood sugar is. And the hemoglobin A1C is a very good test to tell us our 3-month average of our blood sugars. What happens is our red blood cells that carry our oxygen in our body usually last about 3 months, and they collect sugars as they go around our body. And we kind of analyze how much sugar is on there, and they tell us where our sugar average is. And this really helps helps us judge the control of someone's blood sugars. Because often we'll have someone come in and say, well, I had pizza and ice cream last night. That's probably why my sugar's high. But this gives us a 3-month average, so it's not just a spot control. And often this is a main guide of our treatment.
Dr. Thomas.
Yeah.
I'm going to ask a question right now. Can somebody just have a higher blood pressure or blood sugar level, like just that's the way it is, they're higher? Or is a higher number bad and does mean that you have diabetes?
Well, I will often tell people that if they're sometimes in that pre-diabetes range, 106 when I test it, or 110, we know that most of the time for normals for our tests, we have a curve, and 95% of the people fall in that curve. But we have to have 2.5% of people who fall outside that curve. So some people are just set slightly over. So instead of a normal being, let's say 75 to 100, it might be more 80 to 105 or 85 to 110, and that's just kind of where they're set. So if you have an elevated blood sugar when we're fasting or not eating, which is what we usually use, that's over 126, then it's probably less likely something that's normal. It's probably more along the lines of diabetes. The nice thing is if we have that blood sugar and we notice it's high, we confirm it with that A1C number, and that really tells us. So we may catch someone on the wrong day and they really didn't fast, but they think they did. And if we try to confirm it with that hemoglobin A1C, that one-time blood test that tells us about 3 months, it's very helpful because a lot of times that'll actually tell us where they're at. I hope that answers it.
Yep, all good. Thank you.
Perfect. Great question, though, because I do find that quite a bit that people will be in that slightly elevated range for years and years and years from a younger age. So we do look into that. So once we start to notice either a borderline blood sugar or we know we have a family history and we want to prevent things, we often think, well, how can we prevent getting diabetes? And obviously the first two things out of my mouth are going to be diet and exercise. Well, for diet, a big aspect is we try to cut carbohydrates. I'll usually talk to people because they'll usually think of sugary drinks and they'll tell me they don't eat much for sweets or sugar, but carbohydrates are in so many things. We think of sugary drinks tends to be the bane of my existence. So sodas, juices, coffee drinks, especially nowadays with a lot of flavor or filling or creamer or something that has a lot of sugar in it. But we also have to think of alcohol, pasta, rice, breads, and then being from Antigo, it's always hard to say, but potatoes is another one that's a lot of carbohydrates. So really adjusting our diet to kind of limit those a little bit more is very, very helpful. There are a lot of diets out there nowadays, but the DASH diet, which is kind of an oldie but a goodie that we use for high blood pressure, helps a lot for diabetes as well. And the other one that's proven very well is the Mediterranean diet. Now, a lot of these will emphasize leaner meats, more vegetables, a little bit better fats, fruits. So those are the kind of things we shoot for. We hear about the keto diet nowadays and the paleo diet, and they're very good for limiting carbohydrates. The big trouble with those that we don't know enough about is the long-term effects, because they don't limit certain fats. So sometimes we have more problems because of that. But it does often help with blood sugars and weight early on, especially. The other aspect is exercise. Now, I alluded to it before as being a risk. What we try to shoot for is about 2.5 hours a week of exercise. And we try to do that in increments of 30 to 45 minutes. And it's great if you do more than that at a time. But if we stick to 30 to 45 as the time phrase we use or time frame we use, it tends to help us make people do it or suggest people do it at least 4 days a week. Because if you do 45 minutes 3 days a week, you're still 15 minutes short. So if someone goes over 45 minutes, I'll often say, well, stick to, if you did an hour and a half, just call it 45 minutes, because I want you to do it, try to shoot for 4 days a week at least. Moderate intensity exercise is helpful. That's a good walk where you're not kind of strolling, but you're going at a decent pace. Maybe it's a little bit harder to hold a good conversation, or biking at a mild pace, less than 10 miles an hour or so, is actually a good moderate intensity exercise. And there's lots more. The other aspect is starting a medication sometimes in the pre-diabetes area, where we actually prevent diabetes from forming by bringing it down with a diabetic medication. I'll talk a little bit about that in a minute. But our goals for our A1C, and again, that's the 3-month test that we use, in the beginning especially, is to have that number less than 7. We know our outcomes 10, 15, 20 years later are better if we can get a little bit better control in the beginning. And often I'm telling patients, I'm not worried about your health now, I'm worried about your health 15 years from now. As we go along and we have other conditions, sometimes we shoot for about 7.5. And then we do know that as we age, maybe we're 80 years old or more, if we're a little bit more frail, we want to avoid low blood sugars. So then we're a little bit more relaxed. So we shoot for 8 for that A1C number. But a lot of times people come in and say, I don't want to do insulin. There's a pill for this, right? And we have to consider things like cost and efficacy. How well does it bring down our A1C, and what are the side effects? So I bring up metformin again because it's usually the first line therapy for this, and that's because right now the cost is low. They haven't raised it back up on us. It does do a significant drop for our A1C. People don't have a weight gain because of it, and we don't get low blood sugars, which sometimes is a side effect. Side effects that do happen, so metformin specifically tends to be GI side effects, but a big thing that's been in the news last year and this year is the whole NDMA. It's the carcinogenic or cancer-causing chemical that's been contaminated in some medications. Last year there was a lot of blood pressure medication issues. This year it came out with some certain stocks of metformin. So I'd get calls saying, should I be on metformin? And I hear it causes cancer. Well, the big issue is where it was contaminated in a couple lots, but metformin itself is a fantastic medication. But that's something we have to really consider with medications. And if metformin doesn't do enough for us, we have to think about, well, are there other pills for us? And there's lots actually out there, but we have to kind of keep those other considerations in mind. So Trulicity, Victoza, Byetta, that's one class. Invokana, Jardiance, these are lots of medications we often will hear a lot about on TV commercials. They're excellent medications. They reduce heart risk. They reduce chances of gaining weight from medications. But the other aspect of them is the cost. I mean, sometimes trying to find these medications for patients under $300 a month is very difficult, and we have to look for coupons and other things, which then sometimes leads us to using things like Actos or the glipizide in the lower levels. They're good medications that have been around for a while, but a big aspect for them is they have more side effects. So we do have lots of weapons at our disposal, let's say, to treat diabetes from a medication standpoint, but sometimes the availability is the difficult portion of it. So the last thing people want to do is poke themselves, checking their blood sugar using insulin. And once we get to the standpoint of insulin, we start checking our blood sugar 2 to 4 times a day. We're using long-acting insulin, that's once a day. Short-acting insulin, that can be up to 4 times a day. These will bring down our blood sugar as well, but that's kind of where we end up sometimes if we don't prevent it, or we're not successful preventing it or using medications. The other problem is once we diagnose diabetes, we actually increase our testing. Our A1C, we want to find out twice a year, sometimes 4 times a year. We check our urine for leaks of protein to show early damage from diabetes, and we will start getting cholesterol more often. We don't always have to get it every year, but with diabetes we do. And the other problem is because of the risk that we have with diabetes, we actually want people to take more medicine. So one of them is a cholesterol medication, the statin class that people often know about. The biggest aspect is we're trying to reduce our cardiac risk. And since diabetes is such a high risk, statins help lower that. And the same thing with a blood pressure medication. So even if your cholesterol is good, we'd still use the statins. Even if your blood pressure is good, we try to use this class of ACE inhibitors or ARBs. If you've heard of lisinopril or captopril or losartan, those types of medications, they really protect our kidneys in diabetics. It's the one thing we really want to decrease the chance of having is kidney damage and dialysis. So we try these medications at very low doses. So that's a lot about prevention and how we treat and diagnose, but then we have the coronavirus going on now. So there's not a lot of data out right now with diabetes, but we have to look and see, well, how is the virus affected by diabetes and how is diabetes affected by the coronavirus? So we know when we get an infection, and coronavirus it actually seems to have a lot of this. We get a big inflammation or inflammatory response. Our body's just really irritated. And what happens with that is our body doesn't tolerate insulin as well. It doesn't use it as effectively. And our blood sugars go up, and they can go up, and they can go into the 500s. They can go into the above 1,000. And that causes a lot of symptoms. We can throw up and have a lot of abdominal pain and get really dehydrated. And it leads to two different types of illnesses called DKA or HHS. I won't go into those in depth, but those require ICU treatment to hydrate someone and bring their insulin or their blood sugar down quickly but safely without overshooting and get those low blood sugars. So coronavirus does have a big effect on diabetes. The other question is, well, how does diabetes seem to affect coronavirus or their outcomes? We know that we have increased risk in hospitalizations and length of stay for hospitalizations, for ICU need, and even death or mortality. There are a few early studies. Now, I want to emphasize these are early studies when we were mainly testing people who were very sick in hospitals already. We didn't have quite as much testing for people who had less symptoms or maybe asymptomatic even. So these numbers will all go down, but the ratio is going to be fairly similar. In an early United States study, they had almost 15% mortality in diabetics compared to 6% for others. And in China, there was one where you can see the numbers were less because they probably had a higher population that they covered in the beginning, but 7.3% compared to 2.3%. And in the United Kingdom, they even had a 1.8 times more likely to have a fatal infection. So diabetes in someone who's infected definitely played a role in your outcome. And the biggest aspect is we want to control our blood sugars because the less controlled you are, the worse the outcomes seem to be. So someone who had a controlled blood sugar of around, or an A1C of around 7, like we shoot for, 6.5, did a lot better usually than someone who was 8, 8.5, 9. So the outcomes got worse as the A1C rose. So we know that the virus affects diabetes, but we know having diabetes has an effect on our outcome. So diabetes is a big subject, and I kind of went with a lot of information quickly in short strokes, and a lot of these are bigger talks, but we know it's essentially just elevated blood sugar, but prevention with diet, exercise, and perhaps even medication, and knowing our risk factors is very helpful, and then treatment, fairly well controlled in the beginning, is very helpful, and we know that there's issues with the virus that's going on now. So I'll leave it at that. That's all I had for today. I'm going to try to get out of this screen, and if anybody has more questions, I'd be happy to answer them.
Thank you very much. Thanks, Dr. Thomas. Is diabetes considered an autoimmune or an endocrine issue?
So it's a great question. All diabetes are considered endocrine issues because of the hormone we're talking about. That when we talk about endocrinology, we're talking about hormones, and both types of diabetes, if we specifically are only talking about type 1, type 2, there's actually more, but they're both endocrine. We consider it that way. Now, the autoimmune portion of it, a lot of times we think more with type 1 diabetes as far as how your body has initially caused problems with your pancreas early on, so you can't form insulin. And that's usually the child that finds it. Sometimes we don't find type 1 diabetes till we're in our teens, and rarely later, but it does happen. But that's usually more the autoimmune process.
And can you go back to the difference between type 1 and type 2?
Sure. And
does that matter with COVID at all? Type 1 and 2 and then COVID?
That's a great question. I actually didn't touch on that. So, and I'm sorry, 90% of adults are type 2, and that's because they developed it later in life, and I probably emphasized more of this talk based on that. Type 1 is usually childhood diabetes, or is what sometimes people will consider it, because they from an early age they really can't produce enough or any insulin eventually. And type 2 diabetes is usually we make insulin, we get more and more resistant to it, so we have to make more and more and more to control our blood sugars. And eventually we kind of burn out our pancreas sometimes and actually become type 1 because we can no longer make the insulin. But there's not a lot of studies for type 1. Most of it's under type 2 for the coronavirus or for COVID-19. But the early numbers show it's a very similar aspect of people do much poorer when they have type 1 diabetes as opposed to not having diabetes at all. They haven't compared as far as which one seems to be worse or anything, but they do have, when they've done some of these studies, they've had small subclasses of the people who are type 1 and show they still have similar poor outcomes as far as compared to not having diabetes.
Okay. There's another chat in the feature right now. Does Central Wisconsin have a greater degree of diabetes than other parts of the state?
You know, I'm not 100% sure about the epidemiology for it. I can tell you from my clinical experience, I feel like a higher percent of my patients here compared to, I worked at Freighter at the medical college for 5 years, and I feel like I was dealing a little bit less with it there than here. And sometimes it has to do with the type of occupations we have around and what we were exposed to younger as far as meat and potatoes and things like that with how we eat and portion sizes. So I'm not going to be able to give maybe a definite answer to that, but clinically, I kind of feel that way.
Somebody asked, why is my blood sugar higher after an 8-hour fast?
And that's a tough one because sometimes people will believe that if your body is used to a certain blood sugar and you fast for an extended period of time, your body doesn't like having it low and you'll start releasing your blood sugar stores. So when we don't use our blood sugar for energy right away, we store it. Our liver helps us do that. And when our blood sugar kind of gets lower or we need to, it pushes it out. So a lot of times, even that's a way we sometimes attack with medications, is trying to avoid the liver from helping us make new blood sugar to push out to use for energy. But a lot of times people might have that little swing at the end of an 8-hour fast that makes their test a little bit off.
Okay. And can you explain the dawn phenomenon?
You know, I would honestly defer a lot of that to an endocrinologist, but a lot of that has to do with a huge drop and then a huge spike afterwards, where you rebound higher than you need to. That's a controversial one because some people don't really believe it exists. They think it has to do with a different process, but it's a very interesting question, and that's one I would probably say an endocrinologist would be best to explain it for you. So,
Okay.
Great question, though. It is an excellent one.
Is there a difference between an 8-hour fast or a 12-hour fast or a 24-hour fast regarding diabetes or the testing for diabetes?
So when we do a fasting blood sugar or glucose, I prefer to have an 8-hour fast because most of the time, if we're doing fasting in our real life, it's about 8 hours. So I kind of link that more with how we're doing. And we usually shoot for 8 hours on the fast when we do the test. But some people will do 10, 12 hours, and we have to be careful with that. But it has to be at least the 8. So there's not much of a difference. If we're worried that people actually make too much insulin, we have them fast longer and longer to see if they go low. But usually our bodies don't do that.
Okay. There is another question in the chat right now. There's a recent article about sustained periodic periods of fasting. Can that help with weight and blood sugar levels? And what's your thought on that?
You know, there have been lots of articles on this for years. In fact, I had several patients about 6 years ago when I was in Milwaukee. Sorry if my dog's loud. In Milwaukee, that brought me a few articles on the periodic fasting. The tough thing is those articles, and I'd have to see the specific one, but a lot of those articles use small numbers, and sometimes they're a little bit more, you can actually cherry pick a little bit, having good results and kind of get rid of the bad results for some of those articles. So we have to be careful and have to look really delicately at how they did the studies. But there is some belief that if you do have some fasting, your body, when it gets something, will want the sugars, handle it, get it out of the blood, and put it into the cells right away for energy, so you don't have as high of blood sugars. So there might be something to it, and I have several patients who have been successful for it, but with it. but it's one of those that we don't also have a lot of long-term studies to see how well the body will handle that. So, and if you decide to do a diet more like that, are you going to sustain it? And if you're not, how are you going to change coming out of it to keep our blood sugars under control as opposed to going back? I started rambling. I do this in the office all the time because it excites me. So, so I'd have to see there, because there's lots of articles that come out about different types of diets, and the intermittent fasting diet is a very interesting one that some people have a lot of success with. So,
do most people who come into your clinic think they have diabetes and that's what they're coming in for? Or are they coming in with other symptoms? Like you talked about tingling, or you talked about different symptoms that you then lead to diabetes.
I think most of the time, if I'm finding diabetes, it's because I did a routine screen on someone who came in, whether they haven't been in for a while or if it was their yearly visit and it was kind of trending that way. I will say the two symptoms that I tend to find the most, if someone's coming in specifically with a symptom, it's the urinating and the thirst. And then they Googled it and they found out, oh, I think I have it. So some of my new patient appointments have to do more with those symptoms and finding out if they have diabetes and going from there. So those are probably the two main symptoms, but most of the time we find it when people don't have symptoms.
And can you cure it? I mean, if you come in pretty early, can you cure it, and then will it come back later?
So you can cure it, and that's the tough thing. They don't like when I take out of the chart that you were a diabetic and you've cured yourself. They prefer to call it diet controlled diabetes. So it really it depends on who you ask. But the best feeling in the world is when a patient gets their A1C down less than 6.5 or down less than 6 and being out of the pre-diabetes range, depending on what you read, with diet and exercise. And a lot of it usually has to do with if it's early enough when we first diagnosis, sometimes it's 5 or 10 pounds and adjusting those carbohydrates. And you can do it without medication. I wish it happened more because I would love to prescribe less medications for it, but it does happen and it makes my day, let alone I'm sure the patient. So yeah, so you can cure it, and yes, it can come back. And a lot of it has to do with can you maintain what you did to cure it? And another aspect is, as well as we age, we become more insulin resistant anyway, so it might come back even though you're continuing to do the same thing. But that usually is way down the road. And by then, we often can control it pretty well and easily, I'd say.
Okay. How about gestational diabetes for a mother? Does that have any risk later in life?
We do see a higher risk for diabetes later in life with gestational diabetes. In fact, we probably screen a little bit more closely. So when I have younger patients between 35 and 50 and younger, we don't have to do blood sugars every single year. But with gestational diabetes, I kind of treat it more as a pre-diabetes, even though if their sugars aren't there to begin with, and make sure I'm screening at least once a year for it. Yeah.
Okay. Thank you. I'm going to open it up if anybody else has any questions. We have been monitoring the chat this entire presentation, so thank you for those of you who have been texting in and asking a couple of questions. If anybody wants to come off of mute or wants to turn their camera on, this is certainly the time to do that. Dr. Thomas has given us a pretty full load of information tonight. Again, this was recorded, so we will keep this, and this will be on our website for additional information. But if anybody has any questions, please. We are happy that your dog is participating in this conversation.
I'm going to let her outside really quick. Give me.
Okay. Dr. Thomas will be right back. This is the world that we are living in today, being virtual and working from our homes. So thank you very much.
As I put in the chat room, I'm just happy my dog under my desk isn't responding.
I have two girls who are watching my dog right now for me, and that was how successful it was. So.
John, do you have any questions?
No, I appreciate the information tonight. Thank you.
Wonderful. Susan or Lori, do either one of you have any questions? Either one of you want to come off of mute and ask anything to Dr. Thomas?
No, I think this was great. He did a great job and very informative.
Thank you.
I was going to mention, this is Susan. So the reason I asked, I was the one that asked if it was endocrine related or, what did I say? Endocrine or autoimmune, because my brother and I are 13 months apart, and he was diagnosed with type 1 diabetes when he was 27, and I was diagnosed with hypothyroid. Like the same year, adults, nothing beforehand. And I just thought, wow, that's really weird.
So I'll put it this way. It's a great observation. Autoimmune things tend to run in families. And if one person has one autoimmune thing, we tend to worry they'll get another autoimmune thing. So thyroid probably being the most common. So diabetes, interestingly enough, type 1 diabetes doesn't run in families as much as type 2. So a lot of times when we see autoimmune things, it doesn't always have to be type 1 diabetes and type 1 diabetes. But often if someone has one autoimmune thing, we do see other autoimmune things in families. They do kind of run together like that. So thyroid is much more common in women, and type 1 diabetes is kind of split, if I remember correctly. But it's one of those where he may end up with hypothyroidism because of the autoimmune aspect as well, because he's already got one autoimmune thing. So that's a great observation for the autoimmune portion of it.
Thank you.
Yeah.
Thanks for answering that.
Yeah.
Well, everybody, I really appreciate you joining us tonight. This is a great way to connect, and we will continue to do more of these. I believe this is our 4th or 5th or 6th one that we have done since March, and we will continue. We have another one hopefully in the works for September and October. Different topic, different subject matter, but again, tell your friends, tell other people, because we would love to have more people on. Dr. Thomas, thank you for your time tonight. We really appreciate it.
Sorry about my dog.